All right. Good evening, everyone, and welcome to our virtual Speakeasy. It's your first of 2021, our first of 2021. I'm Jim Malowitz, the investigations editor for the nonpartisan and nonprofit Wisconsin Center for Investigative Journalism. And past editions of our Speakeasy event series have explored the issues surrounding the 2020 November election in Wisconsin, disinformation in the age of coronavirus, and how former Wisconsin Watch interns and fellows are reporting on the pandemic around the world. We want to thank Wisconsin Public Radio, our partners in so much of what we do, for co-sponsoring this event. And you can find info about WPR's upcoming events at wpr.org/presents. So before we introduce our speakers for the evening, I'll share a bit about the Wisconsin Center. The center was founded in 2009, and besides publishing investigative journalism, we also train our interns and fellows to become the next generation of investigative journalists. You can find our stories, sign up for our free newsletters, and financially support our work at wisconsinwatch.org. You can also follow our various social media accounts, including, most recently, TikTok. And our work also appears in newspapers and on the radio and TV stations around the state and country. And that's because we give away our stories for free to other news organizations. In-depth journalism is expensive, and neither the Wisconsin Center nor WPR shield our work with paywalls. So we rely on the support of people like you. So if you find value in trustworthy, nonpartisan news, please consider becoming a member of either organization, or better yet, both, by making a tax-deductible contribution. So steering tonight's discussion, we have Bram Sable-Smith. He's the WPR Mike Simonson Memorial Investigative Reporting Fellow, based virtually for now in the Wisconsin Watch newsroom. He's been our key reporter covering the pandemic, and he's reported extensively on how it has shaped public health in Wisconsin and exposed flaws in Wisconsin's safety net. He'll chat with New York Times investigative reporter Sarah Kliff, and they'll focus on how the public health crisis exposed flaws in our healthcare system and how journalists in Wisconsin and the nation can make a difference by reporting on these issues. We'll also offer plenty of time for Q&A at the end of the discussion, so if you have questions, and we hope you do, please type them in the chat box at the bottom of your screen, and I'll be able to relay them to Sarah and Bram. Please also keep your microphones muted. And additionally, you may have noticed that we're offering a live transcription of this chat. So now, to properly introduce Sarah Kliff, here's Bram.
Thanks, Jim. Thanks, everyone. Welcome. Thanks for joining us. And thanks very much to Sarah Kliff for joining us. It's very, very exciting to have you here with us. So Sarah Kliff doesn't need an introduction, but here's one nonetheless. She's one of the country's leading health policy journalists, an investigative reporter with the New York Times. She's focused on healthcare. Before joining the Times, Sarah was a senior policy correspondent at Vox and an editor, I believe, where she created and hosted The Impact, an award-winning podcast about how policy affects people. Over the past decade, Sarah's covered everything from the creation of Obamacare and the many, many attempts to repeal that same law, and on to the questionable billing practices of hospitals, including during the pandemic right now. Her reporting has spurred changes to local health systems like the Zuckerberg San Francisco General Hospital, which overhauled its billing practices in response to her stories, in response to her work. And her reporting has also helped spur the passage of federal law, like a very recent ban on most surprise medical bills passed through Congress late last year. She's a frequent television guest, has appeared on CBS, PBS, Fox News, CNN, MSNBC, and now, most prestigiously, Wisconsin Watch and WPR Speakeasies. So Sarah, thank you so much for being with us.
Yeah, thank you for having me.
So I want to start out by asking you, at the very beginning of the pandemic, you wrote a story about the ways that the healthcare industry was changing and the way that hospitals were evolving to change with it. And so I wonder if you can start out by telling us a little bit about what was going on then. How was the industry upended? How did hospitals respond? And is that still the case 1 year later, now that we've had some time?
Mm-hmm. Yeah, so I would say, 2020 was a really wild ride for the health sector. You had this moment, nearly a year ago at this point, where everything shut down. And that was especially true in the healthcare sector, where, scores of elective procedures were canceled. I remember I had a follow-up to a broken foot. I didn't go for the follow-up x-ray because nobody was doing anything. I was just staying home. And kind of that, what I was doing is what everyone was doing. And all of a sudden you had this healthcare system that is used to growing and growing. Each year the healthcare system grows and it gets more revenue. It all of a sudden the revenue just dried up, and the things that were going away were actually the most profitable parts of the healthcare system, like these elective surgeries, like joint replacements or scans. For example, the x-ray that I didn't get on my foot, those tend to be the profit centers of our healthcare system. So you had this moment where it felt like the healthcare system was really in crisis, and in a moment when we needed our healthcare system to work really well, right? Because we had this new disease, we didn't understand how it worked. But you had these kind of twin things going on of the healthcare system being busier than ever fighting COVID and being slower than ever because all these procedures had been canceled. So there was this moment, and I think it was a moment I wrote that story, if I remember correctly, I think it ran last May, where it felt like the healthcare system was, maybe going to have to change. They're going to have to do something to adapt to this new reality where, people were going to the doctor less. But it turns out the healthcare sector had a really fantastic rebound. And I think, if Bram's reporting and my reporting, I think both of us have shown that the healthcare system is quite good at making sure it gets paid, and will often go to pretty extreme measures to collect debts from patients. So, we did have and I think, we did have this moment where it felt like, oh my gosh, are the hospitals going to close? What's going to happen? But you got to the end of 2020 and the healthcare sector actually looked pretty fine. There was a huge amount of stimulus that rolled out to hospitals and doctors through, the various laws that were passed here in Washington over the past year. You saw healthcare systems really pivot to telemedicine pretty quickly. So that was another way they're still continuing to see people. So at the end of the day, the healthcare system has kind of emerged, with the same business model it had going into this. That being said, I think there are certain parts of the healthcare system that are struggling a lot more than others. I think of, rural hospitals that, were kind of on the margin before this are still having a lot of challenges. Primary care doctors and pediatricians, generally the lowest reimbursed specialties, they've really struggled as a lot of that primary care, or particularly pediatrics, really has not come back. Kids are getting a lot less sick because they're not in school, which is generally a good thing. But if you're a pediatrician, all of a sudden, all those well checkups you need to do for sports, all those, sniffles that toddlers are getting at daycare, all of that business totally goes away. So you have these pockets of the healthcare system, and they tended to be the ones that had the smallest margins that are having some struggle. But then if you look at like the big players and like the big hospitals, they're generally doing okay. And it seems like there was this moment where we thought everything might change, but it actually looks like we're kind of just shifting back to, where they were before the pandemic.
What do you attribute that to? Is it because we swooped in and rescued the hospitals, or have they just done it themselves?
Yeah, I think a lot of it was at swooping in and rescuing the hospitals, and they had a strong case, when they're making this case for stimulus funding and for this provider relief funding that, was since created, where, look, they needed to be stable and able to fight coronavirus. And so we're really making a compelling case to Congress. We need these subsidies to stay afloat. Like, if you want our healthcare system to stay open, then you're going to have to help save us. And then you kind of saw the volume really, all those canceled procedures, a lot of them got done. Some of that care is never going to happen. That x-ray I was going to have on my foot, like, I just didn't have it. And that's revenue that will just, disappear from the system. But those, profitable joint replacements, a hip replacement surgery, that person probably still wanted hip replacement surgery, by the end of 2020, and ultimately went and got it. So I think a lot of the care was deferred rather than just completely canceled. And then you had a really big stimulus package that kind of helped keep things, afloat through the end of 2020 into 2021.
Our cases were spiking in September, and one of the local hospitals here invited, I had a chance to go to visit a COVID unit at a local hospital here. And, they wanted reporters to come in and see how overwhelmed their COVID units were, so we could kind of relay that message as cases were really spiking in Wisconsin. but when I got there, my biggest takeaway was I was just shocked how busy the hospital was. It seemed like, I hadn't been anywhere near a hospital in 9 months, and it seemed just like it had been before I left it. It was really surprising.
Yeah, I think you're right. And if you look at the data, I think that's actually pretty representative, where you have even seen through this new wave the new waves we've experienced, the healthcare system keeps gaining volume. And I think people are feeling more comfortable going out, now that we know more about social distancing and how to prevent coronavirus, people are feeling a little more comfortable being out and about. But I think you're exactly right. There really was this recovery. And I think it's why, hospitals lobbied for a lot more relief in the stimulus that just passed, and they didn't really get it. Rural hospitals did get some funding, but I think the message they're bringing to legislators this time just wasn't that resonant. It seems that, legislators kind of decided like they're doing fine. They don't need another health system bailout at this point.
Sarah, how's your foot?
Oh, it's better. I tripped and broke my foot a few weeks before quarantine when my dog got out of the house. But luckily it healed fine without the x-ray. Good.
Okay, so you do all this reporting on the healthcare system, and you go about it in a really novel way I wanted to ask you about. So you ask people to send them your medical bills, and these are things that I just find so overwhelming. I get so many of them, and it's just hard to even open the envelope because I know I'm going to understand so little of it, but you actively seek them out.
Yeah, so I've been doing this for a few years with a few different projects. And, so one of the things that struck me in about a decade of covering the healthcare system is the pricing is just so opaque. We know from academic research and just from our own lived experience that the prices are really, really high. They're the highest in the world. Much more than Canada, Europe, any Asian countries, our prices are just a multiple of everybody else. But it's really hard to know how much it's going to cost. So it's expensive, but it's very, very hard to know how much it actually costs in a specific place with a specific type of health insurance. And that information you typically don't get unless until you get your bill. So you go to the doctor and then you find out how much it's going to cost after you've received all these services. And there's really very little space to negotiate or work around that. So a few years ago, I kind of came up for an idea, where I really wanted to look into the cost of emergency room billing. I'd had a few patients send me some pretty outlandish bills. And, the best way I could think to do it was just to get a bunch of bills. Patients actually have some really powerful information in those bills. They have information that hospitals and insurance companies generally want to keep secret. They have the exact price it costs to use their facility. So I came up with this idea, I think it was in 2017, that, and this is when I worked for the website Vox, what if we just ask people to send us their medical bills? And we had no idea how well it was going to work. I'd never really done anything like it. Our legal department had a bit of a heart attack when I suggested collecting a bunch of personally identifying information, but luckily they were really wonderful to work with and really wanted to make our journalism work. So we, figured out a really secure way to do it. And we ended up having over 2,000 people send us emergency room bills. And it really led to, a lot of wonderful stories and a lot of different hospitals' billing practices come to light that we wouldn't have been able to find without those patient bills. And now I'm doing a similar project at the Times with coronavirus testing and treatment. So it's, it's kind of flipping, I spent the beginning of my reporting career, writing mostly about policy, kind of looking at the policies. I've been based in Washington, D.C. for all that time. And I'd look at the policies that were passed in Congress and how they affected people. And I've kind of flipped that, over the past few years, where I've started with looking at people and what they're going through, and then kind of working upwards to understand, okay, what are the policies that are leading to these outcomes that people are having?
So you've learned some interesting things about coronavirus testing, how much they cost different people. What have you learned? Can you tell us a little bit about that?
Yeah, coronavirus testing is just such a good reflection of, a lot of the things that don't work really well in our healthcare system. And coronavirus testing has kind of become this little mirror to the way our healthcare system functions. So a few things I've learned. I've been collecting these bills since August. I have about 700 of them at this point. And I have learned, the prices are incredibly variable. What people are being charged and what providers are being paid is just all over the map. I wrote a story about a month or two ago about pediatricians who were not even getting paid as much as the cost of supplies. They were getting paid maybe $20 or so for COVID tests when the cost of actually buying the cartridge was, $30 or $40. And then you also have some providers who are getting paid, hundreds, in extreme cases, even thousands of dollars for conducting coronavirus tests. And, it really speaks to our fragmented healthcare system that you have two people providing, pretty similar services and yet getting paid, 10 times more or 10 times less, depending on kind of where they are, how they're coding their bills, if they're adding extra things to their bill. So I've learned the prices can be quite high. I learned they vary a lot from one place to another. And I know there's just a lot of billing that isn't working the way Congress intended. So when Congress passed federal legislation in the spring, they wrote rules that are supposed to mean that your insurance company covers the entire coronavirus test. You should not have to pay any copayment or deductible. But there are a lot of people who are facing those. And, I even ran into this when my son needed a COVID test in December. The urgent care I took him to billed me a copay. And, I did ask a question at the front desk. Like I knew from my reporting that this was an illegal copay, but I also knew my kid needed a COVID test. And like, I was not going to fight with the person at the front desk at like 7 p.m. at a pediatric urgent care. So I've lived it in my own experience. And, I've also read a lot of bills of people who, were charged copays that they actually should not have been held responsible for.
So if you're extrapolating up from those, individual data points, including your own very frustrating one where, someone who theoretically knows the system well gets trapped in the same kind of predicaments, what's the bigger point to extrapolate there? If people are getting paid different amounts, if people are having to pay copays and are unable to, not do that, to advocate for themselves in a way that they don't have to pay that copay and still get the care they need, what's the larger thing that we can extrapolate from there, policy-wise or
Yeah. Yes, and I think kind of like in my view, what happened is Congress, they saw coronavirus and they decided to write special rules for it. They decided to make the coverage for coronavirus different than the coverage for most other things. So they wrote rules, they wanted to make sure Americans, and I understood the intention here was to make sure Americans were financially protected from coronavirus. So they wrote these rules that said no co-payments. And if you're uninsured, there's a fund that hospitals and doctors can submit your bills to. The whole idea was to make the cost of coronavirus free to patients. But I think, the takeaway that I have is those rules just don't play nicely with the way our healthcare system works, where it's just, accustomed to billing patients and everybody having to pay something for their care. And so you see this with, the COVID copays, where, and I think a lot of this, is some of it might be nefarious, but some of it is just insurers have these systems and they're used to charging a copay for an urgent care visit. And if it's not coded just so to make it clear that there was a COVID test, and actually this should get the special rules instead of the normal rules, then a bill gets sent out. So I think healthcare providers, we're in a lot of cases trying to code to the best of their ability, but the whole system is set up to bill. The system is not set up to make it so people don't pay anything. And you see this also, with other parts of how, we've tried to kind of make this little oasis for coronavirus within our healthcare system, but then, the rest of the sea of our healthcare system kind of keeps impeding on it. Another example is a story I wrote a few weeks ago about a man in Texas who was in the hospital for 5 days last April with COVID-like symptoms. And the doctors went back and forth if he had COVID, if he didn't have COVID. They ultimately did not diagnose him with COVID because his testing was kind of ambiguous. And it turns out that was a huge deal because he was uninsured at the time. He'd actually spent 1 month uninsured. He was 17 days short of qualifying for Medicare. He was 64 years old. So he was uninsured and he had a $22,000 bill. And if the hospital had diagnosed him with COVID, the hospital could have sent it to this federal fund for uninsured COVID patients, but the hospital didn't diagnose him with COVID. So he was no longer a COVID patient eligible for this fund. And it just kind of speaks to the brokenness of our healthcare system that, a diagnosis can mean so much for whether you get this crippling bill or not. And I think it also speaks to the way, Congress tried its best to try and, keep all of us safe from these coronavirus bills. But when you have a healthcare system like ours, it's really hard to do those kind of carve outs, kind of the normal ways of operation, just find their way, into how we're doing things.
Yeah, like ours, meaning when we have so many millions of people uninsured. just
Mhm.
exposed to bills like that.
Yeah.
Okay, so staying on aggressive billing practices by hospitals for a second, you uncovered a pretty interesting story earlier this year. So you were writing about something that we found here too, although there's subtleties from state to state, something called hospital liens. Can you? I mean, they're complicated. They're complicated. What's kind of like your top line basic explanation of what a hospital lien, and then
Yeah.
how hospitals exploiting them?
And you should step in because you know this area well. And you might have found this is also a hard story to pitch to an editor because it's very something bad is happening, but it's like very complicated and hard to explain. So my basic definition, or at least what I found, was going on with the story I co-reported with one of my colleagues, was that you had hospitals who were refusing to bill health insurance because they wanted to pursue certain patients for the full bill charges. And the patients they would pick are auto accident patients because they likely had some kind of settlement that they could go after. And in our reporting, we found, at some hospitals, they tended to do this most frequently with Medicaid patients. Medicaid is a program that covers low-income Americans. It typically pays the lowest prices. So there's kind of the greatest financial incentive with the Medicaid patient. You're going to get the worst payments if you bill insurance. So there's more of an incentive to, go after that person's settlement for the full bill charges. You should talk about this too, because you report on this issue. The thing that was so outlandish to me was just the refusal to bill health insurance. I've been writing about our healthcare system for a decade, and I kind of assumed when I give someone my health insurance card that those benefits will get billed. But it was surprising to me to learn reporting this, that that's actually not the case. You can have your lawyer send your health insurance benefits and they still might just, decide not to bill them. You've reported on this too. Kind of what jumped out at you about this particular story?
I think it's one of those things that has its interesting twists and turns depending on what state you're looking at. So in Wisconsin, number one, the hospitals will go after patients who have been in auto accidents. One, because there's likely to be a settlement, but two, because all their information's right there, because you can just get the records from the auto accident. I still owe the Milwaukee Police Department some money for a records request I put in to get some of these details. So all the information's right there for you to put in the system and try to bill it. As I was talking to an attorney who represents people in legal accidents, so there's kind of he's got some interest in this, but he's saying there's limits on the amount that that people can go after, that people can recover in these kinds of settlements. And so if the hospital bills are high enough, the lien will put a hospital in line to get paid before anyone else. If the hospital bills are high enough, it won't even make sense to go for a settlement, because after the hospital gets paid, is there enough money to pay a lawyer, and will anything even get to the person who's been in the accident? Chances are probably not. The other interesting thing is that there's like a set amount of time for you to file a hospital lien in the state, and it's a matter of weeks to do it in Wisconsin. And so whereas a hospital might spend a really significant amount of time trying to find insurance information or get a patient enrolled into one of the charity care programs to pay for their care if they're uninsured, they're filing these liens before they have a chance to know whether the patient's even insured or not. It's kind of file a lien and then figure out if you need to drop it later. So it's an interesting world for sure.
Yeah, it is. And you're right. The rules vary so much by state. Like there's some states I found where they limit what share of the settlement can go to the hospital. And then there's other ones, like where the hospital could take the entire settlement. Some states require that actually have rules requiring that health insurance be billed first before a lien is filed, and then the lien can cover some extraneous stuff. And then other ones have, more open ones where the hospital is not required to bill insurance. So it's just like, it feels like I keep running into, I've been doing this for a while, but I feel like I keep running into these like little pockets of the healthcare system that continue to, surprise me and kind of amaze me at these, terrible billing situations that Americans find themselves, falling prey to.
Well, it's almost time to open up for the Q&A with the audience, but I want to ask you one more question before we get there about a recent story that you had out this week about you were looking at maternal mortality and the impacts that this COVID relief bill actually could have on reducing the maternal mortality rate in the country. Now that's wrapped up in Medicaid expansion, which is something we don't have in Wisconsin, and something that's very unlikely to happen in Wisconsin. But I wonder if you can explain a little bit about what's going on with maternal mortality in the United States. Why is it an issue? What stands out about it? And how does this bill or Medicaid expansion, part of it, how does it have a potential to impact?
Yeah, so the United States has a very high maternal mortality rate, and different from our peer countries, it actually has gone up over the past few decades when it's been going down in other industrialized countries. Our maternal mortality rate is 5 times higher than Germany, twice as high as Canada. It's a real crisis, and ProPublica and NPR did a wonderful series about this a few years, really highlighting the issue. And so what is in this new stimulus? I think one of the things that's so interesting about this stimulus is there's so much going on in it. There are the checks that most people have heard about. There's the child tax credit, but then there's all these other kind of almost, wish list policies that Democrats have wanted to do for a while that are, related to some kind of pandemic relief, but also kind of reflects the priorities of the policy. And I would kind of put this in that bucket. So this is a policy that just went into effect. Well, actually, I should back up a little bit. So right now, the way public insurance works is if you are a new mom who gives birth with Medicaid, and 45% of births in the United States are financed by Medicaid, you get health insurance while you're pregnant, you get health insurance for 60 days after having your baby, and then you don't have any sort of public option. And at that point, about half of moms who deliver with Medicaid become uninsured. And it's probably quite obviously a pretty vulnerable time to lose health insurance. We know that about a third of maternal deaths happen in the year after giving birth. So this is kind of a critical moment when we have a high number. The uninsured rate for new moms is actually higher than the general population. So what this legislation does is it allows states to extend postpartum Medicaid coverage from 60 days to 1 year to ensure that moms have coverage for a full year. And it actually could matter a lot in non-expansion states, such as Wisconsin, because you don't have to sign up for the rest of Medicaid expansion to do this. You could just cover this particular group of people. So I think you might actually see a number of southern states. Texas, for example, has not expanded Medicaid, but has shown a lot of interest in doing this postpartum Medicaid expansion. So it could be a bit of a stopgap in states that haven't expanded Medicaid to at least get to this particular vulnerable population. So a lot of people are pretty excited about it. I think you'll see high take up of it is optional, but I think it's not nearly as polarizing as the Obamacare Medicaid expansion. So I think you might see a lot faster and more politically varied take up of that option.
Great.
We'll see.
Looks like we've got some questions queued up here.
Cool.
And I will fire them off. I'll look at the first question to Mike Crane, who asks, is telemedicine profitable? Seems like it requires fewer people, and is curious that for a while there was no copay at his provider. Mike says, I think the quality of care can be lower because the physician isn't making a physical assessment. Any thoughts about telemedicine?
Yeah, it'll be interesting to see where it goes after this pandemic. So generally, before the pandemic, telemedicine tended to be reimbursed at a lower rate than in-person care for exactly the reasons he's mentioning, that it requires fewer staff, requires fewer resources. But then you saw during the pandemic, Medicare increased reimbursement rates so that they'd be the same. So doctors would get paid the same in-person versus telemedicine. And most private insurance companies followed suit. And a lot of private insurance companies also dropped those co-payments. They just had the insurance company cover the entire thing. I think it's a bit, and so some of those policies have gone away, as we've gone further into the pandemic. Some are still in place. So some insurance companies are still paying at higher rates, some aren't. When I've talked to providers, it's kind of a frustration for them as they don't know if it's going to be profitable. Whether or not telemedicine is profitable really depends on what insurers are willing to pay for it. And we feel like we're kind of in an in-between moment where they were willing to pay more during the pandemic. We don't know if they're going to pay more after the pandemic. I think it's a challenge. It's an area that works really well for large providers who can kind of buy the software they need and they have some economies of scale, whereas like small providers getting scaled up on telemedicine can be pretty challenging. And some of them, were on the fence about whether to invest in this or not before the pandemic. Many of them made the leap during the pandemic. So I think it remains to be seen if it's profitable or not. It really depends on kind of where we shake out and where, insurance companies, if they feel like they're getting that value, if they feel like it's delivering as much as an in-person visit, I think that's going to determine, how they reimburse for it ultimately.
Yeah. Questionable whether it's profitable or not. Or an open question whether it will be profitable or not. But potentially a game changer, Mike. I mean, you talk about the people who've been able to access telemedicine during the pandemic. That same kind of gap, it's us in our homes right now not wanting to leave during the pandemic, but during normal times, especially if you're looking in rural areas, like some of the reporting we've done on, you look at addiction treatment services in rural Wisconsin, where you'll have 0 or 1 providers who are able to prescribe Suboxone in a given area, or a really dearth of physicians, or even any kind of primary care physicians. Whenever you go out there, or whenever we go out there reporting, we ask about telehealth and its programs that they have a little bit going. It's kind of going. It's always a question of, will somebody pay for it? So the open question is a really important one, because it does have the potential to really expand access to all kinds of services in all kinds of places. It would be really important, a really important step for filling some of the provider gaps that we have in Wisconsin and elsewhere in the country.
And so Mary Beth Rowland asks, we've been talking a lot about what's wrong with health insurance. Are there any sort of big picture solutions we should be talking about that you want to highlight? We love solutions journalism here. And any really strong ideas to fix some of the issues we're talking about, and give us any glimmers of hope?
Yeah, so I think you're certainly seeing an engagement with these issues, and you certainly have this debate within the Democratic Party that I think as we get out from the pandemic, we'll see move to the front about, should we be changing our healthcare system in some significant way? Should we be adding in a public option, or letting everybody have the choice to enroll in Medicare, or going even further, do we want to do Medicare for all? Have a system like Canada's where all of us are enrolled in public health insurance plans. So I think that's a debate was really at the center of the Democratic primary, and that I think you might see reemerge next year as we get a little bit further out from the pandemic. There's a little more space to talk about other things. But you are even seeing, even smaller scale solutions. There's, the legislation Bram was mentioning that Congress passed last year that, attempted to deal with one of the most frustrating problems of surprise billing in American medicine, where you go to an in-network hospital, but it turns out one of the providers who sees you is not in network, and all of a sudden you end up with a surprise bill. And it's estimated about 1 in 5 emergency room visits in the US led to a surprise bill like that. And I've written about a bunch of them. Other reporters have written about a bunch of them. They're just these infuriating situations where patients feel like they're doing everything right, and they still end up with a big surprise bill. And Congress passed legislation at the end of last year that makes that type of billing illegal. It essentially says, if you go to an in-network hospital, you are not going to be responsible for any out-of-network bills. That's a dispute between the provider and your insurance company, and the patient is being taken out of the middle. So I think that, is certainly a place where you saw journalists and academic researchers at the same time really identifying a problem. You had academics writing on the scope of the problem. You had journalists kind of telling the stories of what the problem looks like. And legislators took notice of it, and they actually, passed a law that is meant to address it. So that does feel like, a small sliver of progress, even when we spend a lot of time talking about problems. There are certainly solutions moving forward too.
Maybe one more sliver of hope, also tooting the journalist horn, but Sarah, us at Wisconsin Watch and WPR, other organizations, Kaiser Health News, NPR, have been doing stories on things like billing practice, things like suing patients, taking patients to small claim courts over unpaid medical bills, sometimes as small as $200, things like that. And in response to these kinds of stories, there's been changes at hospitals. Hospitals have stopped that practice altogether. They've overhauled their systems. So I think maybe one sliver of hope there is that, some of the inequities that are exposed in this kind of investigative healthcare reporting, it reveals that, things don't necessarily have to be that way. There's nothing that says a hospital needs to take a $200 bill to small claims court to collect on it. So, hospitals are changing their practices in response to some of this stuff coming out. So I think that's a good thing too. It's a chance to think about it and potentially overhaul.
Do you think, Bram or Sarah, just the fact that some of this reporting, obviously both of you have been reporting on the system before the pandemic, but do you think that the fact that everyone is focused on the pandemic makes your reporting more likely to deliver impact? Everyone's focused on healthcare?
Yeah, I don't know. That's a good question. I think you're certainly right that it's been a year when everyone's focused on healthcare. On the flip side of that, I feel like it's also easier for non-coronavirus stuff to kind of fall through the cracks. Like both of us are reporting on these hospital liens, which I think are really important, but there's so many things, legislators could be dealing with. And I think, one of the storylines I'm going to be watching play out this year is, and maybe it's something you guys will be looking at in the state legislature, is how do hospitals use their goodwill and like the great things they did caring for COVID patients? Are they going to use that to lobby in certain ways? Are they going to kind of bring their wish list to Washington and say, we, want these sort of changes. We want to raise our prices. We want to get paid more by Medicare. I think they're at a moment when they have a lot of clout, and I'm interested to see kind of how they use that going into this year.
I mean, I'm following right in line with that. There's a lot of goodwill towards, healthcare providers, specifically nurses. And, the last story that we were reporting at Wisconsin Watch and that we did with WPR before the pandemic hit, it was like the story came out on a Wednesday, and that Friday it's like, oh, we're not coming back to work ever again, was about labor issues at hospitals here in Madison. It was nurses organizing a union, nurses talking about organizing a union. There's been a big push towards nurses organizing unions around the country. And, nurses have a lot of goodwill going on right now because of their work with the pandemic in the exact same way. And I'm very interested to see if that's something that they're going to use to potentially, further their arguments, further their cause in organizing themselves as a labor entity.
So hopefully those are enough glimmers of hope for Chris, who asked for some. Moving on, a question from our boss here at Wisconsin Watch, Andy Hall. It's a personal question for both Sarah and Bram. How has covering COVID-19 changed each of you as a reporter?
Have you burned out, Sarah?
I don't think I've burned out on reporting. I think I've burned out on quarantine. I mean, I think one of the things I found quite challenging is I think I went into reporting because I really like talking to people and interacting with people. And it's been much more challenging to do that through the pandemic. I obviously have not been on a reporting trip since all this started. And that's a little sad for me. But how has it changed me as a reporter? I think it's made me a better reporter because there have been so many good stories to dig into. And you like you were just saying, Jim, when the whole world is focused on one storyline that's pretty close to your beat, it's like a moment when you really want to rise to the occasion. So I think it's really challenged me to kind of do my best at a moment when obviously things are challenging for everyone. Like many people, I have a small kid at home. It's been hard having everyone here, but I also feel like because it kind of came so close to the work that I was doing, it kind of pushed me to, it made me feel, good about spending the time working hard on it, because it felt like it was a moment when really good journalism was needed and really good accountability, was really important to have.
Sarah, how does reporting the pandemic compared to, so you've been there for like some of the biggest, like most intense years of reporting for healthcare reporters, right? So like when Obamacare was first passed, I'm sure it was really intense. I wasn't a reporter yet. And then there's, 6 years of, talking about repealing it. And then 2017 comes and there's actually, a very large, intense push to repeal the law. I mean, I just remember 2017 being an exhausting year for health reporters. But how does this compare to those other exhausting years? I'm sure it must be more intense, right? Or how,
yeah, I mean, it's different in different ways. Like in 2017, I was spending a ton of time on Capitol Hill because I was kind of the center of the action. And, I just, my life revolved around Obama. I got married in 2017. I remember like missing meetings with my wedding photographer because the Republicans were rolling out their repeal bill. But I was so excited to cover it. And, we joked we were going to send an intern to my wedding photographer meeting with my now husband while I covered the bill rollouts. But luckily no intern got assigned to that task. But it felt, it's different, because then I was like really out and about. I was like spending late night on Capitol Hills, and here I think it can definitely be a little isolating that you're doing everything from home. I only started at the Times in June 2019, so the majority of the time I've worked for them, I've been working from my bedroom right here. So I think that's the location is makes a big difference. And I do miss the feel of like being in a newsroom and interacting with other people. And hopefully newsrooms come back after this. I'm optimistic.
How is it different to interview someone, like I'm thinking about, after the 2016 election, you went out and had, these really interesting stories about people who had voted against, voted for Trump as a vote against Obamacare, not realizing that they themselves were the beneficiaries of Obamacare's Medicaid expansion. So, you're talking to people who are in a really intense situation in that point, but you're doing it in person. How does it compare to have the really intense conversations, over Zoom with your kid and your dog and another, your family right there?
Yeah, I mean, I think it's certainly more challenging. It's harder to find the sources too. Like when I did that reporting in Kentucky, I flew out to Kentucky and spent a day with an Obamacare enrollment person, and people were just kind of walking in and out. And there's no way to really sit in on that virtually. So you kind of come up with workarounds. I worked on a story earlier this year, somewhat similar, talking to people who voted for President Trump, but who had Obamacare and liked their coverage, kind of how they made that decision. And all those conversations had to happen over the phone, which, I think it worked fine, but I think you probably would have gotten a better conversation. And, finding those people was different, since I couldn't go somewhere and talk to people. We worked with a polling firm that had polled this question and had asked people if they were okay with a reporter following up. But it's just a lot more work to find people. I dialed through like 40 numbers to find 5 people. Whereas if I'd been able to sit with like an Obamacare enrollment worker all day, you'd kind of have this like stream of people coming in. So, people screen calls. It's harder to get someone on the phone than it is to kind of, ask someone in person to talk to you.
So we have another question from, this is from Colleen. We talked a little bit about telemedicine earlier, but what does the pandemic specifically mean for behavioral health? Has it been a boon for telemedicine in that appointments are maybe more easily accessible over Zoom or wherever?
Yeah, so I think you've certainly seen a lot of the mental health space that you've really seen how telemedicine can be an incredibly powerful tool, where this is a lot of care, like Bram was saying earlier, that can be quite hard to access in rural areas. And all of a sudden telemedicine could have a really liberalizing effect. And I think if you look at the different specialties and how quickly they've adapted to telemedicine, ones that center on mental health, behavioral health are kind of at the very top of it, that they had the biggest shift. And I think that's one where you're going to see a continued shift. You might not see it in primary care as much, but I think when it comes to behavioral mental health care, you will see this kind of continue down the line as a normal way of delivering care. I think the one worrisome sign, that speaks to the first question we got, is is the care going to be as good for patients? We've seen some worrying signs that opioid overdoses are rising during the coronavirus pandemic. And that, I was looking at some research last week where you see initially like good adherence to, whatever regimen you're on telemedicine, but at some point it kind of drops off in a way that you don't really see with in-person medicine. So I think there is some concern about, as a long-term strategy, if it is going to work. But I don't know, it sounds like, Bram, have you done some reporting in that space?
Not during the pandemic, no. I've heard plenty more advertisements for behavioral health services that are happening online. So I have to imagine there's quite a burgeoning market there. But yeah.
We have another question, and this one's from D Hall, also at Wisconsin Watch. Has there been any movement recently towards decoupling health insurance from employment?
I'd say a little bit, generally, the reason that health insurance is coupled with employment is because there's this large tax break that when employers provide benefits to workers, they get to do those as tax-free dollars. So your dollar as an employer goes a lot further if you're buying health insurance than if you're providing compensation. And that's a very, very strong link. That's kind of, a relic of the World War II tax code provisions that stuck with us and actually like hugely shaped our healthcare system. I'd say the one small step I see towards breaking that are some pretty big changes to the Affordable Care Act subsidies that were in the stimulus. So that American Rescue Plan that President Biden just signed last week, it spends $34 billion increasing Obamacare subsidies. So this makes the subsidies more generous for people who are already getting them. It also makes higher income people eligible for the first time to get subsidies. And also particular to this question, there's a provision that says if you're on unemployment insurance, you also qualify for a free Obamacare plan. So that is like a small, a small hammering away at the link. And it's certainly not breaking it. But I do see the Affordable Care Act as an initial step towards breaking that link, where it is now, if you want to leave a job, you don't have to worry about, can I get an insurance company that's going to accept me? Insurers are required to cover pre-existing conditions. So anything you do to strengthen the Affordable Care Act, I think continues to chip away at that link, but the link is still very, very strong. I remember when Obamacare passed, a lot of people were predicting, employers are going to stop offering insurance. They're just going to move everyone to the marketplace because why would they spend money on this when they don't have to? And there's this perfectly good other option. It turns out the status quo is really powerful and people like the health insurance benefits they get at work, which are generally more generous than the Obamacare plans. And you didn't really see, even though some people were predicting kind of the end of employer insurance, you just didn't see any sort of serious erosion, which kind of suggests to me that, you're going to have to take some bigger steps if you really want to kind of weaken that link.
Gotcha. And we just have another question from Andy. Andy says, both of you have produced amazing journalism on COVID-19 during the pandemic, but what essential message about this pandemic still hasn't gotten through to the public that you wish it would? Or has everything gotten through? Got it all.
I'd like to think it all got through. I'm trying to think of what essential message hasn't gotten through. I saw, Bram, you unmuted yourself, so maybe you have something wise and sage to say as I think about this.
Well, I think the area that at least my reporting takes me into really kind of sheds a light. You look at the numbers and you see our COVID numbers coming down. You see like unemployment numbers are generally pretty good. I don't know. I've been feeling like really hopeful lately about the pandemic. Things have been looking up, but I think the reporting that we're doing puts us in a space of the people who are left at the bottom. And like during the election last year, people were talking about the K-shaped recovery, meaning that higher earners, people who are doing reasonably well off to begin with, are recovering quicker, and people who start with less have been struggling longer and suffering longer the economic and health impacts of the pandemic. I think, I don't know. I mean, we report on that. We report on that a lot, but I also kind of think that the general understanding of that doesn't break through in a certain way. It's the area where we're still talking to people where it's not quite a health care story, but I'm talking to people who are still waiting for unemployment benefits. We still get inundated with people who are saying, I've been waiting for months for my unemployment benefits and they haven't come yet. Can you help me, or can you figure out what's going on? And there's some of that in the healthcare world too. I think that's the thing that I don't want to lose sight of. I don't know if it's not that we're ignoring it altogether, but I can see how that could quickly be ignored, or how we could quickly lose sight of that as the general overall picture of the virus really seems to be trending up.
I'll take this in a slightly different direction. So it's more of something that we just don't understand. And I think we've had a lot of trouble kind of making heads or tails of is, what is actually the impact of all these school closures? I think it's become a fierce political debate in an area where I've seen kind of, we don't have a lot of evidence. And as the evidence comes in, it gets quickly politicized. And I think that's one area where, we just don't have great answers. And I think we're starting to learn more and more about what the impact of having kids out of school for an entire year is going to be like. And it feels like this area where you saw a lot of camps just kind of quickly take sides, and we're either kind of like on team reopening or team not reopening, and reading evidence to kind of support their side in a way that's somewhat unfortunate. But so I think that's one area that we don't understand well. And I'd be optimistic that everyone kind of like takes that information with an open mind and kind of working to figure out like what is safe and like what can we be doing and can't we be doing to get kids back in schools.
That's a great one. I mean, I'm reading really smart people on opposite sides of the closing opening argument for schools, and I don't know what to make of it at all.
You and school district administrators,
just want to say we have more than 5 minutes left. So if you have any additional questions, feel free to ask in the chat. I'll go to the one at the bottom of the queue from D, who asked, what's the best explanation for some of the vaccine hesitancy we see? Of course, right now we still have more demand than supply, but we might get to that point where the demand decreases when there's some hesitancy. Why are people refusing to be vaccinated?
Yeah, I mean, it's hard to paint with a broad stroke, why. I think a lot of people have personal reasons. I read a poll that I thought was quite interesting because the work that I cover, that you have when Kaiser Health News did a poll about, not Health News, Kaiser Family Foundation did a poll about vaccine hesitancy, and they actually found the third leading reason was cost, that people are scared that they're going to be billed for their coronavirus vaccine. And I know that's not the very top one, but it struck me as interesting because the work I do in medical billing, that people kind of are just accustomed to getting surprise bills when they interact with our healthcare system. And, it is the case, again, the rules are different for this. Patients are not supposed to pay anything for their coronavirus bills. The actual coronavirus vaccine is paid for by the government. The administration costs are to be paid for by your health insurance company. But again, people are going to fall through the cracks because that is just what happens in our healthcare system. So I think the cost kind of factors in, and there's other things too, skepticism about the healthcare system, there's politics, there's previous interactions with the healthcare system. So I think it's all of those layered together that lead to some level of hesitancy. And it's something I think we'll understand a little bit better, as we get into this moment when we transition from when we have demand that, is no longer outpacing supply. Then I think we're going to understand a lot better, what are the things driving hesitancy.
I just think it's so interesting that in Wisconsin, so far at least, it seems like hesitancy isn't the biggest issue for us. I mean, we're leading the country. We've in the streak now where for several, I think, weeks now, we've been leading the country in the percent of our vaccine doses that we're using. We're at 94, 95% now. It's just a staggering amount. You see other states that are expanding their eligibilities a little bit earlier than us, and their vaccine usage rate is down in like 80 to 85% range, which maybe suggests that if 15 to 20% of the vaccines that you have in your state aren't getting into people's arms, that suggests some hesitancy there. But you would think if you're reading like the headlines, you're reading these stories that have come out about the what we're learning or what polls are saying, at least, about who might be hesitant. You would think that Wisconsin is in there. When you're looking at largely Republican, largely males, these are kind of the stories I've been reading lately. You would think that would hit us, but if you're looking at our vaccine usage, we're really not there yet, and I think that's interesting. So maybe that's the thing that part of the essential story of the pandemic that we've yet to explore, Andy.
And Don Ferber has a question about vaccine distribution. To what extent is there still a problem with distributing vaccines to vulnerable communities of color? And are we seeing a lot of variability in how different states are doing that?
Yeah, I haven't done a bunch of reporting on the variability in states, but I think that definitely is a big challenge, is getting this out to communities of color, or just disadvantaged communities, or folks who are not going to have the ability to get to these mass vaccination sites. So you see these big sites being stood up, but you also want the mobile vans that are going out to places, or vaccinators that are going to apartment buildings. And I think we'll start seeing more of that, particularly with Johnson and Johnson, just because it's going to be an easier one because of the way it's stored and because it's only one shot. That's going to be easier to go out into a community versus one that has to be kept super cold and then you need to make a return appointment. So I think that might speed things up and make it easier to distribute in those communities. But it's tricky. I mean, thinking about the last question about hesitancy, I think there's a lot of hesitancy and confusion about, well, is this good? And are there negative health effects? I've had debates with my friends, should I get Johnson and Johnson or should I get Pfizer? Should I just get whatever is offered to me? And it's hard to parse through, the evidence. These are complex trials that were conducted in different places in different ways. People might read the headlines about AstraZeneca and get a little worried about the vaccine. So I do understand, there are people trying to grapple with some complex science that moved quickly, and that might be something else that could contribute to hesitancy. And, the reason that Johnson & Johnson makes me think of that is I think there is one of my colleagues had a story recently about, a worry of, are people going to feel like Johnson & Johnson is the second tier vaccine if it's the one, kind of being rolled out to disadvantaged communities. So I think that's kind of a stigma that will also have to be grappled with. There's just so many different public health issues that are coming up here that are really novel and new and kind of new things that we're confronting as we go.
Yeah, it seems like you appeared in my reporter's notebook with this question, because this is a story that I'm working on right now to see what we're doing about access, how we can expand access. I was talking to a pharmacist, a community pharmacist in Milwaukee, the Hyatt Pharmacy. They work with a lot of underserved populations. So they work with the Black community, they work with immigrant communities, they have people on staff who can speak, I think, English, Spanish, Arabic, Hmong, a lot of language. So they have a lot of experience trying to get, just serving those kinds of communities. And then earlier, earlier in the pandemic, they started to get a lot of experience doing COVID testing in those communities. And, when the state rolled out a system that required an email address and the ability to speak English in order to sign up for COVID tests, that was an issue for a lot of people who they were serving. So they built up the system. They built up their system to, they hired people, brought people on board to be able to navigate people through the process of signing up for a COVID test so that they could deliver that. They're now applying that to the COVID vaccine, which they're doing as well. And the other step that they've taken to try to get, if you're like me, you're hunting around on Walgreens and Walmart and, calling your providers and doing all this stuff to try to sign up for a vaccine appointment, and you're willing to travel somewhere. But that's if you have time, that's if you have the technology, that's if you have the know-how. This pharmacy, Hyatt Pharmacy in Milwaukee, they understand a lot of people don't. So they've started offering a walk-in clinic where you can just walk up, and if you qualify, you can just get your vaccine right there. Now, there's a lot of that's led to a lot of lines. He told me they vaccinated over 1,000 people in a given day, and that can potentially present some of the same problems. And if these like vaccine hunting groups online is full of people who say, "Oh, I have the time, and I know that clinic is going to offer walk-in appointments." Well, we'll all just go to that clinic and get our shots there. So even a walk-in clinic isn't a simple, easy solution to address that. So this is an area I'm exploring now. I'm having more conversations with people, seeing how, people are reaching out to farm working communities, how people are reaching out to Hmong communities, reaching out to all these kind of underserved communities where we think it's important to distribute the shot, but our state statistics show us that those populations are getting, a smaller percentage of those populations are vaccinated than the general white population in the state.
And we are running out of time, but Natalie Yar has a really good question that piggybacks off of that, specifically about the country's undocumented population. She mentioned she hasn't heard much reporting on how what plans are to vaccinate undocumented immigrants, and what do either of you kind of know specifically about that issue, and what questions do you still have?
Because that's not an area, maybe Bram, you've done some reporting in that area. I haven't. My understanding the vaccination process is it does not require any sort of proof of citizenship. It does not even require proof of health insurance. You do not have to have health insurance to get a vaccine. So I think in terms of eligibility, things should not be that different. I think the question is that if people are going to feel comfortable coming forward to a vaccination site, if there's going to be some concerns about their undocumented status. So I think it kind of speaks to what Bram was just saying about this being a population where probably a lot of outreach is going to be needed. And, another different source of vaccine hesitancy might be confronted with this particular group.
I mean, I would throw that to an intrepid bilingual reporter who maybe works at, a publication called the Capital Times. We'll see.
Well, with that, we will wrap things up. Thanks everybody for joining us, and thanks Sarah and Bram. That concludes our Speakeasy. If you found value in this event, in this conversation tonight, please consider becoming a member of Wisconsin Watch or WPR. And you can also donate to Wisconsin Watch by going to wisconsinwatch.org/donate. And you can also find Bram's health reporting and more of our stories on our website, wisconsinwatch.org. And of course, on all of the social media accounts, Twitter, Facebook, Instagram, and TikTok. And sign up for our free newsletters at wisconsinwatch.org/subscribe. Thanks again for attending, and have a great night.